Hello everybody, and welcome to the beginning of Unit 3. Happy whenever time this is for you. Unit 3, man. Halfway through the units. I may have given that away. There's 4. I think that's in the syllabus though. So I wanted to start Unit 3 a little bit differently, obviously, as you can tell. Unit 3 is the unit of uncomfortable ideas and thoughts and discussions and people being uncomfortable about sharing stuff. And that's completely understandable. Unit 3 discusses mental illness, dementia, and end of life. As far as mental illness and dementia, we have a lot of baggage that's come with us from popular culture and how it's portrayed and what it's like. And there's a stigma to that still. Dementia is a difficult topic to discuss, and end of life, people have been asking questions about end of life since people could think, and it's never gotten more comfortable for anybody in the entire time of human history. Also, sometimes students will struggle in this unit, not really academically so much as with the concepts, because it's difficult to describe a break in reality or end of life. I can do it abstractly, I can do it academically, but if you haven't seen it in some way, it can be sometimes difficult to feel it, or not feel it, to understand it, whether it's you've seen this professionally or you've experienced it personally with someone in your family. So this is difficult. So if you find yourself struggling with topics or ideas in this, please let me know. That's what I'm here for. Okay, we're going to discuss just kind of essentially this is a vocabulary lecture. Sorry, but like I said, there's a lot in popular culture that's wrong about mental breaks. We'll say breaks from reality. And what that means. And I feel like we need to unpack that before we get started because these are terms that you will be seeing. So like I said, this is breaks from reality. Excuse me. What that means, what the terms mean. Like I said, I'm not expecting you to be an expert, but these terms will be used and it's good to be familiar with them and what they mean. So first we need to discuss neurotypical and neurodivergent. And also, if I could put psychological disorders on this slide, I would have done so. I just don't have the real estate because they all fit together. For the longest time, the idea, or I guess the general goal of psychology and psychiatry was to make people normal. Take someone who is having some sort of disorder and make them normal. The problem with that comes that normal is defined by the society and the culture that you're in. So not everybody is normal given if you drop them into different social groups. Also, it came up as time went on, people began to say, do we really need to make people normal? Is this an issue? And just as an example, and this isn't, I'm not trying to get politics or personal philosophies or religion involved in this, but as an example, homosexuality was a psychiatric disorder until very recently. They've written it out of the book of their DSM-R book now, but it was for a long time. That's just as an example. So these things shift and change, and the idea that we need to get everybody back to a set standard is kind of falling by the wayside. So what they have now is neurotypical and neurodivergent. And please bear in mind, I'm painting with very, very broad strokes here. I'm in no means qualified to discuss the nuances of this. So neurotypical is someone that demonstrates the behaviors and reactions and thinking patterns that you would normally expect from somebody under a given stimulus. Neurodivergent is the opposite of that. It's somebody that has atypical thinking, behavior, and reactions to a given stimulus. Now, the reason that that's important is because separates a bit from psychological disorders. Psychological disorders are, again, broadly defined, dysfunction in an individual that's associated with impairment and a reaction that is not culturally expected. It typically must impair them from normal interaction and societal function. And this is where we kind of also run into some questions. How much impairment? How much friction? There are always going to be rabble-rousers in any group. Is it, how much do we want to tamp down on what people are? And I know that sounds like a really thorny question, and the psychiatric community is well aware that this is a thorny question. And you can read, even as I was, polishing this up and redoing it, there are debates now on how much do we need to be involved, how much should we be involved, to what right do we have to change somebody. So if you have been going through this so far and thinking, why can't they agree on something? It's not just us. It's not just geriatricians. It's not just dietitians. All of the fields have these discussions. As far as for the disorders, many appear to be related to neurochemical imbalances, either an inability to make the correct amount of a neurochemical or the ability to use it properly. It's almost like diabetes of the brain, if you will. That's kind of a poor analogy, but it's either we're not making enough or we're not using it properly. Other than that, the etiology of these things are very poorly understood, and it's assumed that there are likely multiple causes for each one. Go ahead, please. Thank you. There you go. So contrast this with dementia. And again, we'll go into more on both of these later. Dementia is, let me back up. If you consider psychiatric disorders as chemical imbalances, essentially, dementia is like chronic brain disease. This is a disorder of mental processes due to physical damage of the brain. There's more than one type of dementia, and it is the signs and symptoms of it are completely related to what part of the brain is breaking down. And this is literally, again, this is a mechanical failure of the brain. Broad strokes, again, they're marked by disorders of memory, personality, and reasoning. And how the symptoms cluster is how you know what you're dealing with. Okay, so psychosis. And this is where we need to start kind of unpacking, as I said, some of those terms that we use in the general parlance versus what we need when we're speaking in a professional capacity. Delirium is one. And you may have heard somebody who's like, oh, that person is delirious, or they're completely wrong. They're delirious if they everything that's going to happen, or someone who's deliriously happy, which means somebody who's like happy to beyond the scope of what you would consider to be appropriate to the situation. In medical terms, delirium is an acute onset of severe confusion. There's more than one way this manifests. There's hypoactive delirium, which is in which someone is inactive, sleepy, tired, depressed. And again, that's another word that we need to mention. Depressed does not mean in this case bummed out like it would for, again, the general use. Depressed within medical circles means more along the lines of lack of emotion, lack of feeling, or at least not as much reaction as you would expect in a given circumstance. There's also hyperactive, in which that person is agitated or restless, and if there's anything they nail on the head, it's this one. This is in the movies when you see someone wake up and it's like, where am I? Who are you people? Why am I here? Why am I strapped to the bed? That's hyperactive reality. That's hyperactive delirium. And then they have mixed, which I feel is a bit cheaty. It's just people vacillating between the other two. Maybe they felt they needed three because, I don't know, design. Now, delirium is often due to physical factors, whether this is like drugs or alcohol or dehydration or an infection. But the point is that once the physical issue is resolved, the delirium often also resolves because it was simply triggered by the psychosis. It was triggered by the physical issue. There we go. Wow, I'm struggling. Let's get off this slide. All right, delusion. Delusion is, as opposed to a delirium, which is an acute onset of confusion or separation from reality. A delusion is a long-term, incorrect, false belief that is firmly maintained despite contradictory evidence. This actually is a definition that general use nails on the head as well, kind of like that hyperactive delirium. Excuse me. Now, we're not necessarily talking about Illuminati and lizard men, although we certainly could be. The difference here in this case is that in medical situations, the delusion is due to a medical cause. So you have a patient that believes in lizard men and the Illuminati, not because they fell down a Facebook rabbit hole and can't get their way back out, but because they have a tumor, for example, and the tumor is causing altered thinking. Hallucinations. Hallucinations are one that, not so great on the presentations of this in popular media. A hallucination is an acute instance of perception of something that does not exist. Now, it's acute in that it lasts for a little bit and then it goes away, but there also can be recurring, and it can be the same hallucination over and over, or it can be a different one. Now, we do want to separate this from, everybody has their senses play tricks on them. You think you hear something, you think you see something out of the corner of your eye, and you don't. This is much more manifest. This is like hearing voices talking to you or seeing a thing that isn't there. And while auditory is the most common and then visual, it can be anything. Any and or all of your senses can experience a hallucination. And there are stories of people that have seen parades marching down their hospital hallway, and they have the sights, the smells, the sounds, all of it due to some sort of medical issue. Okay, now, come on, there we go. I have technical difficulties. Really quickly, also, we're going to discuss interventions. And the interventions, these are the three broad ones, but again, there are more. The interventions will depend on who you're dealing with. Reorientation or refocusing is a direct confrontation of an incorrect belief. So if you have somebody who says that there are monsters crawling on the ceiling, and you say, no, Fred, we've talked about this, there are no monsters on the ceiling. Remember, we've discussed this, monsters don't exist, they're not there. Redirection is distracting a patient in order to stop a damaging behavior. Typically, this is a self-damaging behavior when people who are lacking the ability to communicate, excuse me again, when they can't make their needs known, they'll get frustrated. They may lash out at other people or often themselves. So you see them hitting their heads, or they may be clawing at their faces, or trying to hit somebody else, or kicking furniture. And in this situation, you're giving them something else to get their mind off of what it is that's frustrating them, while you figure out what the stimulus is that's causing the problem. And validation is agreeing with the patient on a viewpoint. In long-term care, we often call this going where they are. So if you see somebody who's 85 and says, I'm waiting for my parents to pick me up, but we don't argue that point. We say, you can say, I hope you guys have a great time. When are they coming to get you? Validation, sometimes people feel uncomfortable validating something like that. You can simply just say, oh, that's nice, and move on. The point is we're not directly conflicting or directly confronting a incorrect belief. And guys, that is the vocabulary portion of this. I will see you for more fun and games in psychological disorders. Guys, have a good one. Talk to you later. Bye.